There is a layer of fat inside your abdomen right now that is not doing what fat is supposed to do. It is not sitting quietly in storage, waiting to be drawn on for energy during periods of reduced intake, the way the fat beneath your skin behaves. It is metabolically active, releasing hormones, producing inflammatory signals, interfering with the function of the organs it surrounds, and communicating continuously with your liver, your pancreas, your heart, and your brain, in ways that have been progressively mapped by researchers over the last 2 decades. Most people think of belly fat as a cosmetic concern, something to be addressed for the way it looks in a mirror, managed with exercise and caloric restriction, and measured by whether trousers still fit. They understand, in a general way, that it is not good for their health. What almost nobody has been told is the biological reason why belly fat specifically, not fat elsewhere on the body, but the fat inside the abdominal cavity, is one of the most consequential tissue states a person can carry in terms of cardiovascular risk, metabolic disease, cognitive decline, and longevity. The distinction matters because it changes everything about how the problem is understood and how it is addressed. There are people in this video's audience who have a normal BMI who do not think of themselves as carrying significant excess weight, who have been told by their doctor that their weight is fine, and who are nevertheless carrying a visceral fat burden that is silently driving insulin resistance, systemic inflammation, and cardiovascular risk at a level their body weight has never suggested and their standard health checks have never captured. Belly fat is not an aesthetic problem with health consequences. It is a metabolic organ, and it is one of the most dangerous ones in the body when it grows beyond its designed capacity. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years working in the AANDE, I've cared for patients whose cardiovascular events, metabolic crises, and organ failures have been silently prepared by years of visceral fat accumulation that their standard health metrics never flagged as a serious concern. My goal now is to give people the biological framework for understanding what visceral fat actually is, what it actually does, and why addressing it is one of the highest leverage health decisions available to anyone in midlife. If you're watching this video, the way your body has been changing around the abdomen is something you have probably noticed, whether or not you have identified it as a health priority rather than a cosmetic one. I want to make you a promise. I promise to keep creating the most detailed, evidence-based videos I can, grounded in clinical experience and the latest research to help you understand your body and protect your long-term health. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and haven't genuinely learned something new, feel free to unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I've learned from nearly a decade in emergency medicine. Please hit subscribe to help this channel reach more people like you. And let's get into it. To understand why belly fat is more dangerous than most people realize, you first need to understand that not all body fat is biologically equivalent, and that the subcutaneous fat is the fat deposited immediately beneath the skin. The fat you can pinch. It accumulates across the body in patterns that vary by genetics and sex, and while it contributes to body weight and BMI, it is metabolically relatively inert. It stores energy, it provides thermal insulation, it participates in modest hormonal signaling. In most people with normal metabolic function, subcutaneous fat is not a primary driver of disease. Its presence is not clinically benign in large quantities, but it is a fundamentally different tissue state from what we are discussing here. Visceral fat is the fat deposited inside the abdominal cavity, surrounding and infiltrating the liver, the pancreas, the kidneys, the intestines, and the omentum, the fatty apron of tissue that drapes over the intestines. It is not accessible to the fingers, it does not show on a simple bathroom scale, and it does not respond to standard weight management in the same way as subcutaneous fat, because it is not driven primarily by caloric excess alone, but by the hormonal environment, specifically by chronically elevated insulin, that determines where and in what form the body deposits energy. A person can reduce their overall body weight and still carry a disproportionate visceral fat burden if the hormonal driver remains unaddressed. The weight comes off subcutaneous depots first. The visceral fat proves substantially more resistant. Visceral fat and subcutaneous fat are not the same tissue carrying different quantities of the same risk. They are biologically distinct, and the distinction determines whether excess fat is primarily an aesthetic concern or a systemic medical one. Here is where it gets critically important, and where the conventional understanding of belly fat as simply stored energy fundamentally misrepresents its biology. Visceral fat is not inert storage. It is a highly active endocrine and paracrine organ that communicates continuously with virtually every major metabolic system in the body. Visceral adipocytes, the fat cells within visceral depots, are metabolically distinct from subcutaneous adipocytes in several critical ways. They are more sensitive to lipolytic signals, releasing free fatty acids into the portal circulation, the blood supply that drains directly into the liver at a substantially higher rate than subcutaneous fat. This portal delivery of free fatty acids drives hepatic lipid accumulation, promoting non-alcoholic fatty liver disease, impairing hepatic insulin signaling, and increasing the liver's production of VLDL particles, the precursor to the small dense LDL that is the most atherogenic lipoprotein fraction. The liver is, in a very real sense, being bathed in the metabolic output of the visceral fat that surrounds it. Beyond the direct portal effect, visceral fat is a prolific producer of adipokines, signaling molecules that function as hormones, acting on distant organs and tissues. In healthy, appropriately sized visceral fat depots, adiponectin, an anti-inflammatory, insulin-sensitizing adipokines, is the dominant signal. As visceral fat expands beyond its functional capacity, adiponectin production falls and the pro-inflammatory adipokines take over: TNF-alpha, interleukin-6, leptin, and resistin. These molecules promote systemic insulin resistance, sustain chronic low-grade inflammation, impair endothelial function in blood vessels, and activate the HPA stress axis. They do not act locally, they act throughout the body, on the pancreas, the cardiovascular system, the brain, and the kidneys simultaneously. Visceral fat also contains a high density of macrophages, immune cells that become activated as the fat depot expands and hypoxia develops within the tissue. These activated macrophages are themselves major producers of TNF-alpha and interleukin-6, creating a self-sustaining inflammatory cycle within the fat depot that feeds systemic inflammation continuously. Research published in Cell Metabolism has characterized the macrophage infiltration of expanded visceral fat as one of the primary mechanisms through which obesity-associated inflammation becomes chronic, self-perpetuating, and tissue-damaging. Expanded visceral fat does not simply represent stored energy waiting to be burned. It is an inflammatory organ, an endocrine disruptor, and a continuous metabolic insult to the liver, the cardiovascular system, and every tissue downstream of the portal circulation. The third dimension of this issue is the one that makes it most clinically dangerous, and the one that is most consistently missed by standard health assessment. The relationship between body weight and visceral fat burden is far weaker than most people assume, and for a significant proportion of the population, it is essentially non-existent. The phenomenon of tophi, thin outside, fat inside, describes individuals who carry a normal or even low body weight and BMI, whose subcutaneous fat stores are modest, but who carry a disproportionately high burden of visceral fat. Research published in the Journal of the American College of Cardiology using MRI body composition scanning in a population of normal weight adults found that approximately 45% had elevated visceral fat when directly measured, a finding their BMI would not have predicted in any individual case. These individuals had the metabolic risk profile of obese patients: elevated fasting insulin, elevated triglycerides, low HDL, elevated CRP, despite body weights that their clinicians and they themselves would have considered entirely healthy. BMI is a population-level statistical tool that correlates modestly with total body fat at the population level, and very poorly with visceral fat specifically. It was never designed as an individual metabolic risk assessment. Waist circumference, a direct surface proxy for abdominal content, is a substantially better predictor of visceral fat burden and metabolic risk than BMI, and it is available to anyone with a tape measure. A waist circumference above 94 centimeters in men and above 80 centimeters in women, the thresholds associated with elevated metabolic and cardiovascular risk in major international guidelines, identifies visceral fat risk in a significant proportion of people whose BMI would not raise any clinical concern. A normal BMI is not a clean bill of metabolic health. It is a measure of total weight relative to height and visceral fat. The most metabolically dangerous form of fat is essentially invisible to it. Just very quickly, if you're finding this useful so far, please consider hitting subscribe. It genuinely helps these videos reach more people who need this information. Right, let's continue. So let me lay out the 5 specific pathways through which excess visceral fat damages health, because the full picture makes clear why this is not simply a cardiovascular risk factor among others, but a systemic condition that touches nearly every organ system discussed across this video series. The most fundamental downstream consequence of expanded visceral fat is insulin resistance, and the mechanism is direct. Free fatty acids released from visceral fat into the portal circulation impair hepatic insulin, signaling through the diacylglycerol pathway, reducing the liver's sensitivity to insulin and driving compensatory hyperinsulinemia. The pro-inflammatory adipokines produced by the expanded depot further impair insulin signaling in muscle and adipose tissue throughout the body. The result is a systemic insulin resistance that requires the pancreas to produce increasing quantities of insulin to clear a given glucose load, progressively exhausting the beta cells, driving glucose intolerance, and eventually, in many people, crossing the threshold for type 2 diabetes. The visceral fat is not simply associated with insulin resistance, it is one of its primary causes, and the insulin resistance it drives then promotes further visceral fat deposition, creating the self-reinforcing cycle that makes this condition so resistant to simple caloric restriction. Visceral fat causes insulin resistance. Insulin resistance promotes more visceral fat. The cycle is biological, not motivational, and breaking it requires addressing the hormonal driver, not simply the caloric balance. The cardiovascular consequences of visceral fat operate through 2 parallel and reinforcing mechanisms. The lipid mechanism works through the portal delivery of free fatty acids to the liver, driving elevated triglycerides, reduced HDL, and the production of small dense LDL particles. The lipoprotein profile most directly associated with atherosclerotic plaque formation. The inflammatory mechanism works through the continuous systemic release of TNF-alpha, interleukin-6, and CRP from the expanded visceral depot, promoting endothelial dysfunction, platelet aggregation, and the prothrombotic state that increases acute cardiovascular event risk. Research published in the European Heart Journal demonstrated that visceral fat area measured by CT imaging predicted cardiovascular events independently of traditional risk factors, including LDL cholesterol, blood pressure, and smoking status, confirming that the visceral fat burden carries cardiovascular risk through pathways that conventional risk factor assessment does not capture. Visceral fat predicts cardiovascular events independently of cholesterol and blood pressure. It is not a confounding variable for those risks, it is an additional, direct one. The liver sits at the anatomical and metabolic center of the visceral fat problem. The portal circulation delivers the free fatty acids, the inflammatory adipokines, and the insulin-resistant signals from the visceral depot directly to hepatic tissue before they reach the rest of the body. The result is hepatic steatosis, fat accumulation in the liver, which in its early stages is asymptomatic and detectable only on imaging or liver function testing. As the hepatic fat burden increases and inflammation develops, the condition progresses to non-alcoholic steatohepatitis, and in a proportion of people to fibrosis and cirrhosis. Research from the journal Hepatology has established a direct, dose-dependent relationship between visceral fat area and the severity of non-alcoholic fatty liver disease, independent of overall body weight. Fatty liver in a person who drinks minimally is almost invariably a story about visceral fat and insulin resistance, not about the liver as a primary disease site. The connection between visceral fat and brain health runs through 2 of the mechanisms already described: systemic inflammation and insulin resistance, both of which impair cerebral glucose metabolism, promote neuroinflammation, and accelerate the amyloid accumulation that drives Alzheimer's pathology, as discussed in the dementia video. Visceral fat specifically, rather than total adiposity, has been identified in multiple longitudinal studies as the adipose depot most strongly associated with hippocampal atrophy and dementia risk. The adipokine TNF-alpha, chronically elevated in the setting of expanded visceral fat, crosses the blood-brain barrier and directly impairs synaptic plasticity in the hippocampus. The visceral fat burden of midlife is not neurologically neutral. It is actively reshaping the brain tissue that determines cognitive longevity. The fifth pathway is perhaps the least discussed and the most far-reaching. Visceral fat expansion is associated with accelerated telomere shortening, the reduction in the protective caps of chromosomes that serves as a molecular clock of biological aging. Research published in Obesity demonstrated that visceral fat area was more strongly correlated with telomere length than any other adiposity measure, including BMI and subcutaneous fat. The mechanism operates through the chronic inflammatory cytokine exposure that visceral fat produces. TNF-alpha and interleukin-6 promote oxidative stress in dividing cells, accelerating the telomere attrition that defines cellular aging. Carrying excess visceral fat does not simply increase the risk of individual diseases. It accelerates the pace at which the entire biological system ages, advancing the point at which accumulated damage crosses disease thresholds across multiple organ systems simultaneously. Visceral fat does not just increase risk of disease by disease, it advances the biological clock, accelerating the age at which every threshold across every organ system is reached. Visceral fat accumulation is not the result of insufficient effort or insufficient self-control. It is the result of a hormonal environment, specifically chronically elevated insulin, that directs energy into visceral fat deposition preferentially and makes the depot resistant to mobilization through caloric restriction alone. That hormonal environment is driven by the dietary patterns, the sleep deficits, the chronic stress, and the physical inactivity that a modern environment reliably produces, and that the standard dietary advice of the last 40 years has consistently failed to address at the level of insulin dynamics. The people carrying the highest visceral fat burdens are, in many cases, the people who have tried hardest to manage their weight through the conventional tools they were given. They were given the wrong tools. The biology was always the determinant. So what is the practical solution? I want to frame this carefully because the most important thing to understand about visceral fat reduction is that it requires a different strategy from general weight loss. Caloric restriction reduces body weight. It does not specifically target the hormonal driver of visceral fat deposition. The interventions that most effectively reduce visceral fat are the ones that address the insulin and inflammatory environment that caused it to accumulate, and several of them produce measurable visceral fat reduction with relatively modest effects on total body weight. The most targeted dietary intervention for visceral fat reduction is reducing the foods that produce the most sustained and disproportionate insulin responses: refined carbohydrates, fructose-containing beverages, ultra-processed foods, and the hidden insulin drivers discussed in the Healthy Foods video. This is not a caloric restriction strategy. It is a hormonal strategy aimed at reducing the chronically elevated insulin that both drives visceral fat deposition and prevents its mobilization. Research published in Diabetologia has consistently demonstrated that dietary approaches focused on reducing insulin exposure produce greater reductions in visceral fat than caloric restriction alone, matched for the same degree of total weight loss, confirming that the mechanism through which the dietary change acts is hormonal rather than simply energetic. Time-restricted eating, confining the eating window to 8 to 10 hours per day, is a practical tool for reducing total daily insulin exposure, because the period outside the eating window is a period of genuine low insulin during which visceral fat lipolysis can occur. Research published in Cell Metabolism demonstrated measurable reductions in visceral fat in overweight adults following a time-restricted eating intervention, independent of deliberate caloric restriction. The mechanism is the sustained low insulin window that allows the fat mobilization that chronic eating patterns and chronic insulin elevation suppress. You cannot out-exercise a diet that keeps insulin elevated for 18 hours a day. The visceral fat depot responds to the hormonal window between meals, not to the caloric deficit within them. Among exercise modalities, progressive resistance training has the most consistent evidence base for visceral fat reduction, more so than aerobic exercise alone, and substantially more than the caloric expenditure of the exercise would predict. The mechanism operates through multiple pathways. Resistance training increases skeletal muscle mass, which improves whole-body insulin sensitivity and glucose disposal capacity. It elevates resting metabolic rate through increased lean mass, and it stimulates the release of myokines, particularly irisin and IL-15, that directly signal visceral adipocytes to undergo lipolysis and that promote the browning of white adipose tissue, increasing its thermogenic activity. Research published in Obesity Reviews confirmed that resistance training produces disproportionate visceral fat reduction relative to total fat loss, with meta-analyses showing significant visceral fat reductions even in study participants who did not lose meaningful total body weight. The visceral fat is specifically targeted by the hormonal and myokine signals of resistance exercise in a way that general caloric restriction is not. The third category of intervention addresses two upstream drivers that most visceral fat management strategies ignore entirely: sleep deprivation and chronic stress. Both are primary drivers of visceral fat accumulation through their effects on cortisol. Cortisol promotes visceral fat deposition directly through glucocorticoid receptor activation in visceral adipocytes, which have a higher glucocorticoid receptor density than subcutaneous adipocytes, meaning they are preferentially responsive to cortisol's fat storage signal. Research published in Psychoneuroendocrinology demonstrated that both chronic sleep restriction and sustained psychological stress independently predicted visceral fat accumulation in a dose-dependent manner, even after controlling for dietary intake and physical activity. The goal is below 94 centimeters for men and below 80 centimeters for women, targets that correlate with the metabolic risk thresholds established in international cardiovascular guidelines. I want to be clear that if you are already taking medication for any of the conditions discussed in this video, metformin, GLP-1 agonists, statins, blood pressure medication, nothing here is a reason to adjust or stop without speaking to your doctor first. GLP-1 receptor agonists in particular have demonstrated specific and impressive visceral fat reduction in clinical trials, and they work most powerfully when the lifestyle foundation described here is built alongside them. If you are carrying a significant visceral fat burden and have not had a conversation with your doctor about the full range of available options, that conversation is worth initiating. Let me bring this back to what I see clinically, because the metabolic consequences of visceral fat become considerably more concrete when they are grounded in actual patient patterns. In emergency medicine, the profile of a patient with significant unaddressed visceral fat is one I encounter repeatedly across multiple presentation types. The cardiovascular event in a patient whose LDL was managed, but whose visceral fat burden, visible on the CT performed during the acute admission, tells a different story about the vascular inflammation that had been accumulating for years. The type 2 diabetes diagnosis in a patient who was not overweight by BMI and who was genuinely surprised, because nothing in their prior health contacts had suggested they were at risk. The incidental fatty liver, found on an abdominal ultrasound, ordered for an entirely different indication. In a patient who does not drink and who has no idea that the finding is connected to the belt tightening, they have accepted as a feature of midlife. These are not rare presentations. They are representative ones, and they share the common feature of a visceral fat burden that was never connected to the metabolic trajectory leading to each of them. I have also seen what happens when the problem is addressed at the hormonal level rather than the caloric one. When patients reduce their insulin exposure through dietary restructuring, introduce progressive resistance training, and address their sleep and stress burden simultaneously. The visceral fat responds, the fasting insulin falls, the triglyceride to HDL ratio shifts, the waist circumference reduces, and the patients describe something that does not appear on any metabolic panel but is consistently present: the return of a physical confidence and an energy level they had attributed to aging had stopped expecting to recover. The biology changes because the hormonal driver changes, and when the hormonal driver changes, the visceral fat depot which was built by that driver begins for the first time in years to yield. Visceral fat sits at the convergence of almost every major topic discussed across this series of videos. It drives the insulin resistance that produces the afternoon energy crash, the brain fog, and the 8 metabolic warning signs. It produces the chronic low-grade inflammation that activates the microglia, driving neuroinflammation, and impairs the glymphatic clearance that accumulates dementia risk. It generates the portal free fatty acid load that creates the fatty liver and the atherogenic lipid profile. It elevates the resting heart rate through its contribution to sympathetic activation. It suppresses the adiponectin that would otherwise protect insulin sensitivity. And it accelerates biological aging through the telomere attrition. Its chronic inflammatory output drives. In this sense, visceral fat is not simply one risk factor among the many discussed in this channel. It is a central hub, a tissue state that simultaneously generates and amplifies the majority of the other metabolic and cardiovascular risks in this framework. Addressing it is not one intervention among several. It is for many people in their 40s and 50s the highest leverage single change available, the one that, when addressed at the hormonal level, produces improvements across the widest range of downstream health outcomes. What makes this hopeful rather than overwhelming is that visceral fat is the adipose depot most responsive to the lifestyle interventions that change the hormonal environment. It is the depot that mobilizes first in response to insulin reduction. It is the depot most targeted by the myokine signals of resistance exercise. And it is the depot whose reduction produces the most rapid and the most broadly distributed improvements in the metabolic markers that predict long-term health outcomes. The biology that built it can, with the right tools, begin to reverse it. So let me bring this full circle. Belly fat is more dangerous than most people realize, not because it is a large quantity of stored energy, but because it is a metabolically active organ that has expanded beyond its functional capacity, and is now producing a continuous hormonal and inflammatory insult to virtually every system in the body. It drives insulin resistance, cardiovascular disease, fatty liver, cognitive decline, and accelerated biological aging through mechanisms that operate independently of total body weight, that are invisible to BMI, and that standard health checks were not designed to detect or address. The appropriate response is not caloric restriction alone. It is addressing the hormonal environment, reducing insulin exposure through dietary restructuring, mobilizing visceral fat through progressive resistance training, and the myokine signals it generates, eliminating the sleep deprivation and chronic stress that drive cortisol-mediated visceral deposition, and measuring waist circumference rather than body weight as the indicator of meaningful progress. These are not separate interventions for separate problems. They are a single coordinated strategy aimed at the upstream biological driver of the most consequential tissue state that midlife health management currently under-addresses. The waist measurement tells the truth that the bathroom scale cannot, and now you have the framework to understand what it is saying and what to do about it. If this video gave you something genuinely useful today, a new way of understanding a physical change that has probably been happening for longer than you realized, please subscribe to the channel and help us reach more people like you who deserve this information.